Welcome back, everybody. This is John Malanca with the Association of Cannabinoid Specialists with my colleagues, Dr. Jordan Tishler, Dr. Adam Abodeely, and Dr. Jahan Marcu. Thank you, gentlemen, for joining again and for our community that's watching this evening. The topic that it comes up quite a bit, maybe many of you medical professionals have heard about this topic, but it's called cannabis use disorder. A lot of the medical terms says is a cannabis addiction, marijuana addiction, and beyond. And so let's pick it up, Dr. Tishler. You know, the question always comes up, people always ask me, is cannabis addictive? Is it highly addictive? And I think it's habit forming. I think there are other, actually, I know there are other forms of food and drinks that are higher addiction: caffeine, alcohol, pain medications. And so can you touch up on this?
I often say in response to the question of is cannabis addictive, that first of all, we often misuse the word addiction, and that we really need to separate it into two distinct categories and understand the differences. There's physical dependence, right? And that's where our bodies acclimate to a substance, right? Such that if we then withhold that substance, we get withdrawal symptoms. Right? And you can develop that sort of physiologic dependence to many substances. It's interesting that you mentioned caffeine. Caffeine has roughly the same lifetime 7% dependence rate as cannabis. And so I often, if I'm giving a talk, will say, you know, how many of us can't get started in the morning without our coffee? And all the hands go up. And I say, great, well, you might have a dependence on caffeine just at the same rate as one might to cannabis. Interestingly, of course, cannabis, unlike many other substances, the risk is front-loaded. So we know that teens and young adults have a much higher risk of physiologic dependence at roughly about 18%, which is comparable to benzodiazepines and cocaine and such like that. But that if you manage to live to the ripe old age of 25, your risk actually drops down to about 2 to 3%. So for the balance of our patients who are older than 25, their risk of physiologic dependence is much less. And then there's that question of what do we mean by really addiction, right? So, you know, dependence is a physiologic process. Addiction is a behavioral process, right? This is a set of maladaptive behaviors that arise around the use of a substance like cannabis or opioids or something to that effect. And there's no question in my mind that cannabis use disorder as a behavioral problem exists, but the numbers are much harder to discern from the literature, in part because of that confusion between dependence and behavior, and also in part because there's a fair amount of bias involved in that literature. And so if you asked me what that number for true cannabis use disorder was, I'd have a hard time giving you a number. I can tell you that NIDA, the National Institute of Drug Abuse, quotes as 6 million Americans. Well, that sounds terrifying. 6 million people is a lot of people, but when you work that out as a percentage, you realize that that's 1.7% of the US population. And then when you put that in the context of other substances, by percentages, that doesn't seem necessarily all that high. It doesn't mean that we're excusing that as okay. It means that we're putting it in the proper context.
Thank you for that. You know, you mentioned age groups, 25 and up, 25 and under. Because it's the 25 and under has a developing brain and is more, I want to say, would you say habit forming? I know you work with a lot of patients of all ages, all three of you guys. Is it more habit forming? And the side effects that you do see is, and maybe it's a warning for some parents: laziness, moodiness, not active in sports, not active in home family activities. And so are these things that parents should look out for as, you know, first signs? And then what would you recommend for you know, any parent that's concerned about their child?
You know, I think that a lot of those are pretty non-specific. I think you could take most teenagers and find that they can be lazy and not terribly motivated, and surly and withdrawn from their family. And so, I'm not sure that that's a warning sign of cannabis use so much as it is a warning sign of a difficult adolescence, and that parents need to be paying attention to those kids, the difficult kids, and not leap to the conclusion that it must be, oh, you're on drugs, kid. There are many reasons. And of course, one of the things that has confounded this literature for the last, whatever it is, 6 decades is, you don't know what's the chicken and what's the egg, right? Which is to say, right, it may be that they're using cannabis and that's creating problems, or maybe they have problems and they're trying to relieve those problems with cannabis. And it's very hard, particularly when you're looking at an adolescent population, to discern what is the cause and what is the effect. And then you layer on decades worth of bias amongst the researchers, funding bias through the federal government. These are hard to discern.
I don't want to leave Jahan and Adam out of this as well. With your patients, you work with a lot of, both of you have worked with a lot of patients and spoken about this. Is it with withdrawal, anxiety? Are these things that are cannabis use disorder one of the main, not results, but what you're finding in patients that they're having an issue with the cannabis use disorder? Are these part of the things that fall under the craving, difficulty sleep? I know when I stop cannabis or don't bring, if I'm going on a trip like you, Jahan, and I don't bring, a tincture or a gummy, it affects my sleep for the first couple of days because my body is used to having this extra, sleep aid. But after a few days, 3, 4, 5 days, my body comes back to balance again, where I'm not in need or craving that anymore. So can you both, either of you, Adam or Jahan, touch upon that?
Sure. Yeah. So, with regards to, cannabis use disorder in general, my patient population, is exactly that. It's a patient population. It's very different than the general population from a recreational standpoint. So I feel fortunate to say that cannabis use disorder is not something I see a lot of in my practice. We of course we do the common screening, general screening for substance use disorders or for a propensity of having a substance use disorder in our general intake evaluations. We ask questions like about their past medical history, and does it include things like depression, anxiety, bipolar disorder, substance use disorders, family history. Is there any family history of people that have had, bipolar or other, major psychiatric illnesses, or have been prone to substance abuse in the past? Because these are red flags. In New York State, at least, cannabis is a controlled substance still. And just like any other controlled substance in New York State, we have to actually run what's called an I-stop before we prescribe any controlled substance. And what it does is it shows that we have reviewed in New York State, every controlled substance goes into a database. And so, we get this information ahead of time. So it allows us to evaluate that patient. Of course, if we see that they're on multiple psychiatric medications, if they're on benzodiazepines, these or opioids, we can get a sense of, what's really going on with this, individual. Is there a chance that, they could already have an underlying substance, use disorder, and they're just, trying to stack with cannabis, which, or, get their medical cannabis card for one reason or other. But we do have, pretty good ways of at least teasing some of that stuff out in the beginning. And certainly with, the kids in my population, the children, now these are cancer patients again, and this is a very different, that's a very different discussion than somebody who's maybe using cannabis, on a, a low dose day-to-day basis to control pain or something. The other reason that I think that we probably don't see as much cannabis use disorder in our medical patients is, yes, there's a positive, maybe a positive cognitive feedback from cannabis use, just from THC kind of the pleasurable experiences and gives people. But we do know that from a medical standpoint, and really from from a behavioral standpoint, it has a biphasic effect. So people that don't want to be drowsy throughout the day, well, that's going to limit the amount they take. But it also has a positive effect in the sense that if they escalate doses, oftentimes we see a loss of efficacy of the medication as well. And sometimes then we have to do some coaching, about going on a hiatus or, tapering down or switching to a different, route of administration for a little while, just something to mix it up. So I think it's for these reasons that we don't see, at least in my practice, I don't see a lot of cannabis use disorder. But it's extremely important that we're talking about this. One is because, as the incidence of cannabis use increases, both amongst the recreation and medicinal side, we are going to see more rates of cannabis use disorder, just like we would if everybody started using another sort of substance. We'd see an increased rate of side effects. But also, I think it also speaks to the fact that this is a medicine, and cannabis is a medicine. And when the reason that doctors, pharmacists, people, like ourselves exist is to inform people of not only what a substance is used for, but what are the potential side effects and the pitfalls that you have to look out for. And cannabis use disorder is certainly one of these that, we have to, be very cognizant of. And again, I think it's great that, as a professional organization, we're talking about this because it's real. We're going to see it. Like I said, I think our primary care providers, those who are dealing with patient as a whole, see it a lot more, probably going to see it a lot more than myself, which I guess brings up another point that it's important that, we continue to educate our fellow colleagues about recognizing this condition as well.
Jahan, I know I'm going to give you some time here. Sorry. Adam, you made three great points: biphasal, THC, and medical. Is it only with THC, the cannabinoid THC? Because all cannabinoids play a part. And again, we're all different. It's not a one size fits all. And so, Jahan, you work with you do a lot of studies on this as well, but not only with safety, but also the different cannabinoids. Can you touch up on that? And are you only seeing this cannabis use disorder with THC?
It's a great question, John. And just sort of to kind of summarize before I discuss that, because the landscape is changing for cannabinoid related adverse events with synthetic cannabinoids and these impure derivatives from CBD and other compounds that are being sold as hemp products. So cannabis use disorder, or CUD, is a diagnosis included in the DSM-5 by the American Psychiatric Association. And this is associated with cannabis use with clinically significant problems ranging from mild to severe. So if you use cannabis every day, whether it's medical or not, you would score, you get a mild score on the CUD scale. This is it's an imperfect assessment, but it's being developed more and more. And
Jay,
so
you should mention that it wasn't developed with medical in mind. And so there are some criteria there that are, that make sense in the recreational context that do not make sense any longer.
And I think that's a very important point. And one of the things, to John's question, right, Jordan, is cannabis use sufficient to develop cannabis use disorder? And I think the answer is it can be required, but actually the reason people develop CUD are likely to be multifaceted. There's psychological, environmental factors, biological factors, genetic factors, and the interaction of those things. And those are all important factors. And so now we're seeing an explosion of product diversity, many different ways that people can take the products in different forms, different potency, along with these synthetic products. I know people think the synthetic, they think bad. I mean, nature synthesizes things all the time. Maybe artificial cannabinoids is a better way to say it, but we see Delta-8 that's derived from other products. We see the HHC cannabinoids and a bunch of other THC isomers you've probably never heard of. And this is resulting in a greater and greater increase into poison control centers. And John, to your point, we've been mining national databases, and I'm working on a paper right now on some of the hemp-derived products and seeing a huge spike in adverse events related to them. So, my point is that the appearance of these markets, whether they're illicit, gray markets, very clear gray markets, containing synthetic cannabinoids, has changed the clinical landscape of cannabis-derived adverse events or cannabinoid adverse events. So, I look at cannabis use disorder, its assessments, its scale, almost like a tool. And again, if your only tool is a hammer, everything looks like a nail, but it does provide us kind of a baseline to identify problematic use. And again, it's not really so much about the cannabis as it is about the person developing maladaptive coping mechanisms with something. But there can be genetic factors, and people are looking at things like cannabinoid receptor mutations. They're looking at drug transporter, drug metabolism. For example, one of the things that can lead to, abuse, unintended, intoxication or effects can be how you metabolize these things. Some people might have a more delayed metabolism, a slower metabolism, a faster metabolism, and that might, you'll take an edible, nothing happens. You take an edible, nothing happens, and suddenly you're way over. You're one gummy bear over the line, and it doesn't feel, you weren't trying to get there with the product. And I think when we talk about, so I can imagine someone listening to this, they're going to think like, well, does this mean cannabis is safe or not? We have to remember that, human beings have been killing each other with plants for centuries, but we've also been healing each other with them as well. So I think, again, it's a context question in regards to that. And we have to remember to always come back to the basics. Like, when I think of addiction, I think of uncontrolled use of a substance, even when it has negative consequences. Yes. And that is still part of the cannabis use disorder scale. And then people are concerned because if you score high on the CUD scale and you're under 18, there seems to be a higher association with, that being a more difficult to treat disorder later in life.
So if you do have a patient or you yourself are going to this, what do you recommend helping them, get away from the dependence? Because it's just like coffee. I remember, you stop coffee, next thing you have a headache, you can't sleep, you're moody,
I can speak to the literature about that. And there's been some interesting studies with using just standardized preparations of cannabis. And I think this is where the discussion starts to take some left turns into the boulevard of nuances. Standardized cannabis products, any standardized product doesn't have the same abuse liability as an unstandardized, uncontrolled preparation. Why does it matter whether or not the label is accurate? It is because it increases the abuse liability, the health risks. And, why is Marinol, pure THC, technically safer than just cannabis you might buy at an open air market on the street? Is because the dosing. It's very precise, it's very predictable, and you can't say the same thing for that. So experts, third-party experts in abuse liability studies have looked at this, and that is an important factor. So one is people have looked at using Marinol to treat cannabis use disorder or cannabis-related issues because it is a metered, standardized, reliable dose. People have also been looking at CBD, traditional antipsychotics. There isn't really, in the literature at least, agreed upon this will do it sort of thing. But there's a variety of strategies I think that can be taken, whether it's pharmaco intervention, as it were, replacing it with something else, or other treatment strategies. I think that the simplest one is exercise. Like people who exercise and are trying to cut down on the habit of using cannabis, that seems to really help. And conceptually, it makes a lot of sense because we have an endocannabinoid system and it's triggered during exercise, during stress. And so if you're starting to stimulate your natural system, it might almost kind of help with some of those symptoms. And that's true for a lot of substance use researchers. Are looking at exercise interventions and other behavioral modifications seem to improve people's relationships with those products.
Dr. Tishler, what can you recommend to our listeners when being faced with this with their own patients or themselves?
Yeah, I think that's the right question. There's no hard and fast answers here. And like everything else in medicine, it really is about getting to know your patients and following them closely. so that, you can perk up your ears and be attuned to how things are going for them. I'll give you an example. And I've sort of been at this long enough to actually see things go south on occasion. Thankfully, most of the time they don't. But I've had now a couple of younger folks sort of in that 20 to 25 range where, already we know that there might be some issues, who had significant anxiety disorders, and who we were putting on low doses of cannabis to treat that anxiety. And the thing that's really interesting in the couple cases that I'm thinking about is that they did really well. Like they were on 5 or 10 milligrams for years and doing well with their anxiety. And in both cases, what happened was they decided that they liked cannabis enough that they got a job as a bud tender in a dispensary. And all of a sudden, they went from buying an eighth of an ounce every 6 weeks to buying ounces and ounces a week kind of thing. And you can see that there's a very strong encouragement in the industry at being cued by the environment, by getting discounts, and also, of course, an industry that wants to discount the guidance of the physician. Right. And so, I've worked then with them to sort of help them get into a better job position where they're not getting that kind of messaging all the time, as well as to limit the amount that they can purchase. And unfortunately, sometimes that works and sometimes they just say, screw you, doc, and out the door they go. And that's unfortunate because all we can do is lead them to the water, right? But those are the things that we need to do, is to be mindful of dose and timing and follow our patients carefully so that when problems arise, hopefully we can intervene and, as Adam said, suggest weaning back or possibly in significant cases, actually taking them off the medicine for a while. And that's what we can do.
And Jordan, just to add to that, my own sort of basic research flavor, when we're talking about this, anytime someone is taking a substance for the purposes of changing the way you feel or increasing or decreasing the effects of other drugs or things like that, like there's a fine line between relieving tension and escaping problems. And I think anytime you see this pattern of potentially harmful, potentially problematic use, it's always a good idea, even as a consumer, just to think about it a little bit, to have that moment of pause, to think about why they're using it, and is it, like why are they using it, and do they like the outcome after using it? And if that's a difficult question to ask, I think it's time to consider other products or make some changes.
Absolutely. I often say that the difference between a poison and a medicine is in the intent. Right. I mean, the truth is almost all of our medicines are dangerous, right? They fundamentally are toxins, right? They take a physiologic state and they alter it, right? That's the definition of a toxin. But if we use them cautiously, carefully, sparingly, then that change in physiologic state can be a net positive. And if we transgress, then we've gone into poison territory. And thankfully, cannabis as a toxin has a very wide therapeutic window. But nonetheless, that same theory is important. And particularly, as we talk about the interface between that physiology and the psychology that you're talking about, we need to be well attuned.
One more question before we leave here. With cannabis use disorder, are you seeing, is it mostly with patients smoking versus tincture or an edible?
I would say that probably more with smoking than with other forms, but I don't know that I think that that's a physiologic phenomenon. I think that's a psychological thing, that it is, number one, people who are going to approach cannabis in a more carefree, willy-nilly fashion tend to migrate towards smoking. Yeah. But also it's quite possible to be very dose specific with inhalation, but it requires it requires kind of being on the same page, right? You have to say, I'm going to put this kind of percentage strain into my vaporizer, and I'm going to take 2 puffs, and then I know I've got 10 milligrams, right? Whereas opposed to just kind of puffing away in a more recreational or less mindful fashion, and then the doses are whatever they may be. So I think that inhalation has that additional risk as compared with taking 2 gummies. If you take 10 milligrams in gummies, you took 10 milligrams, right? It's not like you're going to sit there and mow them all down, right? I mean, I hope. So I think that there's a sort of a mindfulness aspect there that's different.
Yep. And I would just include in that mindfulness aspect too. I think it's very important as someone who's studied product labeling and product safety and patient education. It's surprising the gaps in knowledge when it comes to accessing these products. And just because you see, if it looks like trademark infringement, I really doubt Cheetos is putting out their own cannabis brands. If you see that in a store, it's probably not a properly regulated product. It's probably escaping the system that requires testing and oversight. And I think that is also an area where we really need to educate, both consumers need to educate their doctors, and doctors need to discuss it with consumers, because it's an evolving landscape. I was walking in Manhattan the other day, and I went in a corner store because I was just blown away. It looked like a dispensary, and it says like newsstand outside, and you walk in and there's wall-to-wall packaged goods, Delta 8, Delta 9, all derived from hemp. And that it's not clearly labeled what the dose is, how much is there. And that to me is a red flag. If you can't clearly understand the labeling of a product and someone can't clearly explain it to you, like, well, wait, how much is in it per gram? How much is in it per this, per that, wherever you're consuming it? You don't want to get into a situation where you're using a product and one time you use it, you get the desired effect, and another time you don't. You want to avoid that and developing that kind of unpredictability with a product. And so again, it's just my ploy to say my bias is for tested products through licensed sources. We live in an amazing time where we have cannabis essentially as a decreased health risk. That is access through a licensed dispensary, not some brick and mortar operation that's not a licensed cannabis establishment. So I think I just would encourage clinicians, healthcare professionals, and any consumers watching this to always go through the proper channels, because that you're already decreasing your risk associated with cannabis as a factor in your life.
I'm going to end with you, Dr. Abodeely. Any final closing words?
Well, no, I think the main thing that the final thing I would add is, when you think about, when I think about cannabis as a medicine, one thing that I think is interesting about it is it's one of the few medications that we're seeing multiple different specialties actually start to prescribe. We have primary care providers, we've got pain management, we've got people like myself who are in surgery, we've got oncology, we've got neurologists. So, and I think I always stress to people who are new into it is to to beware of some of these potential pitfalls, and cannabis use disorder is one of those. And so I have a very low threshold for reaching out to a patient's primary care provider if we have any concerns, because not only do we not want to get our patients into a situation, if we are focused solely on, so let's say if, for example, I'm treating somebody with inflammatory bowel disease and all I am is focused on how many bowel movements they have per day or how many bloody bowel movements they have per day and their abdominal pain, but I miss the fact that that they're showing signs of cannabis use disorder, then that's not going to be in the patient's best interest. And it also then was going to paint a potentially negative picture when that patient returns back to their primary care physician and they're having, a substance use disorder. So, to summarize all of that, I say, when in doubt, don't be afraid for the specialists out there, to incorporate their primary care providers or another provider who is who's very familiar with the patient, because that is one of my concerns. That as we see people who are very specialized, using the same medication, is that people tend to get blinders sometimes. So I'll leave you with that comment.
For any of our listeners, if you have any further questions about this topic or any, don't be afraid to ask questions. This is specifically why we just put the Association of Cannabinoid Specialists together for our community and for you, our listener that wants to learn about this. And so, Dr. Tishler, the founding member, you want to share with your colleagues how they can find you and find us?
Yes, great, thank you. So please do come ask questions, join the Association of Cannabinoid Specialists. You can find us on the web at cannaspecialist.org. That's cannaspecialists.org. And we have lots of sort of free information. If you join, we have oodles of videos and educational products, as well as a deep library of reference materials. So we really hope that you will come and be part of this conversation, learn from us, teach us, and be part of taking good care of our patients.
Anyway, again, everyone, I appreciate your time for being here with us again for Casual Conversations. Dr. Abodeely, Dr. Marcu, as well as Dr. Jordan Tishler. This is John Malanca with the Association of Cannabinoid Specialists. We'll see you on our next topic. And thanks again, everyone. And thank you, team. We'll see you soon.